It's my pleasure today to introduce Shanthi Sivanandam, who's going to give perhaps one of the scariest titled grand rounds I've ever seen. Before she came to Minnesota, graduated from medical school in Coimbatore, India. And one of the things I learned about Shanthi last night that goes a long way to explaining who Shanthi is that she actually completed a year of cardiothoracic surgery in India and did 100 cases before coming to the United States. She was a pediatric resident here. Then she went to Columbia University for Pediatric Cardiology Fellowship for 2 years and came back for her third year as a Lilly Heart Institute Fellow in Pediatric Cardiology. Since she has completed her education, she has been totally at the University of Minnesota, first as an instructor, then as an assistant professor, and now most recently as an associate professor. She's done a wealth of good deeds, both in Minnesota, serving people at SIWA, Southeast Indian Association, to help underserved people in the Twin Cities, as well as participating in her family's own trust in India that allows children who otherwise wouldn't be able to have cardiac surgery to undergo cardiac surgery, and to go on many medical missions with the Children's Heart Link. Shanti's been the co-director of the Echo Lab for many years and the co-director of the Maternal Fetal Medicine program. She is the director of Fetal Cardiology here, and she's developed a registry with more than 4,000 patients and fetuses in the registry. She's the author of 20 papers, most recently the last 4 years, all developed in association with fetal cardiology. She's acknowledged as an expert in fetal cardiology, and she is a fellow of the American Society of Echocardiography, which is an award granted to those who make a significant contribution to echo. So it's a real joy to welcome her today.
Good morning. Thank you guys for Liz for the kind introduction. It is always a pleasure to come back to my colleagues and present my work, both clinical work as well as research work in fetal cardiology that I collaborate with the maternal fetal medicine physicians here at the Masonic Children's Hospital. So yeah, that title is scary, huh? Womb to tomb, RV programmed in utero. So let me show you what I have for my work. So let's start with the objective of the grand rounds to discuss about the prevalence of maternal diabetes, overweight, and obesity. And what happens to the fetal cardiovascular system? How does it adapt to in utero environment? And what is the long-term impact to the offsprings? And to begin with fetal cardiology, always we have to remember fetal cardiovascular physiology, which was initially shown by Dr. Abraham Rudolph in the fetal model, in the feed sheep model. But then over time, we started to get to know the fetal cardiovascular physiology using our ultrasound techniques. And recently, MRI data, fetal MRI data is actually being pretty much complementary to what Dr. Rudolph has obtained. Maybe plus or minus 5% of the cardiac distributions are slightly different. And it's very important to know that the right side of the heart is the dominant ventricle in utero compared to the left side of the heart during postnatal transition time. RV is the combined cardiac output takes about 60%. Versus the left side takes about 40%. And this is how we talk about percentage of cardiac redistribution in the fetal life. And the mean combined cardiac output that was calculated was about 425 cc's per kilogram, with a ratio about 1.4% is what 1.4. So to me, let's start to transition first. Let's talk about the diabetes in general, why I was trying to focus my research work and my clinical work now towards maternal diabetes and how do we change the future of our offsprings. And this is how the trend is going. This is from the U.S. adult age 18 or older with the diagnosed diabetes, which includes everything, from 1980 to 2012. So we can see a rapid progress of diabetes in U.S. population. And then the percentage of U.S. adults aged 20 and older with the diagnosed diabetes by racial and ethnic group. So at least we need to target these population very carefully. The American Indians and Alaska Natives take over 16%, 13% is about non-Hispanic blacks, Hispanic, Asian Americans about 9%, and about 7.6% to the non-Hispanic white group. And then my focus is on gestational diabetes or diabetic in general during pregnancy and the prevalence of gestational diabetes among U.S. women aged 15 to 44 who had delivered in the hospital setup from 1993 to 2009. It's trending upward from the age of 20, probably 15 to 90 is almost plateaued, but I'm thinking this might also start to creep up over, this is data is from 2009. We are sitting in 2017 at this point of time. So let's discuss the numbers here. Type 1 diabetes, type 2 diabetes. Type 1 diabetes among age less than 20, about 167,000 U.S. youth in 2009. More than 18,000 new cases are diagnosed every year. Non-Hispanic white children and adolescent has the highest rate of new cases. Type 2 diabetes among youth less than 20, more than 20,000 in 2009. More than 5,000 new cases are being diagnosed every year. The rate of new cases are highest in the adolescent group. So gestational diabetes, what is gestational diabetes? So the mothers are pregnant the diabetes is detected during pregnancy. And what is this? It occurs when a woman's pancreatic function is not sufficient to overcome the insulin resistance created by the anti-insulin hormones, which are estrogen, prolactin, cortisol, progesterone, and sabatomamotriphan. The estimated gestational diabetes in the United States is about 2% in the pregnant women. So what is the medical cost involved? The diabetic cost in the United States at this point is estimated to be $245 billion in 2012. So clearly it's going to be higher in 2017. And the direct medical cost is about $176 billion. $69 billion is indirect cost by loss of work, restricted activities, disability, and early death. And then what happens if the mothers are diabetic and if they don't have a good control or they don't even know if they have diabetes during pregnancy? That is, the main focus is during organogenesis. The first 8 weeks of pregnancy where the woman doesn't even know she's pregnant is the crucial time where you really need to control your blood sugars. And if the blood sugars are not controlled, serious birth defects of every kind you can think about can happen. On top of it, we are looking at macrosomia, very large babies, the C-section delivery, I'll be showing you guys the data, preterm deliveries, hypoglycemia, prolonged hospital course, miscarriage or stillbirth, and respiratory distresses because of the delayed surfactant production, which is needed for lung maturation. So what are all the complications we are looking at? Maternal, fetal, neonatal complications. Maternal is preeclampsia, infection, laceration, C-section delivery, and long-term sequelae also can happen. Growth abnormalities, polyhydramnios, fetal demise. Neonatal complications are quite big, including birth injuries, hypoglycemia, seizures, polycythemia, electrolyte imbalance, hypocalcemia, hypomagnesemia, hyperbilirubinemia, respiratory distress, and clearly NICU admissions. And this picture clearly talks everything about it. This is a normal baby. Here's a baby with a diabetic mom who didn't control her blood sugars, macrosomia. What happens to macrosomia? Here are the birth injuries that can can lead from having a very large baby. Let's talk about cardiac issue itself. If the mothers do not control their blood sugars, if the hemoglobin A1Cs are quite low, if they have such volatility to their blood sugars, this is what we end up with, mostly mimicking something called hypertrophic cardiomyopathy. And this is a fetus of a normal heart. If you, with a normal pregnancy, how do you even measure these things? How do you measure the wall thickness? If you're 20 weeks, it should be 2 millimeters. If you're 25 weeks, your myocardium should be 2.5 millimeters. And that's how we go about. So a full-term baby should have a myocardial left ventricular thickness about kind of 3.8 to 4 millimeters. But here you see a heart that is quite hypertrophied. It's a concentric at the same time. There's predominant intraventricular septal hypertrophy, which is not good for long term. We can all say, oh, by the way, it regressed over time, but let's see what happens to these infants over time. So where are we now with our fetal program or with maternal diabetes itself? We have clearly improved in our fetal surveillance and perinatal management, leading to a reduction in diabetes-related complications, including perinatal mortality. But however, the incidence of still congenital anomalies remains high compared to the general population, and congenital heart defects it's about 8 per 100 live births, not 1,000, 8 per 100 live births of infants of a diabetic mother. We are not sure what the exact teratogenic mechanism of maternal diabetes is. It could be multifactorial, but clearly we know that very high maternal hemoglobin A1C values during early pregnancy are associated with increased risk of malformation. What is the future now? Where do we stand? The future is mainly to optimize. I'm not targeting gross anomalies. We are not talking about gross. Here I'm talking about at the micro level, more into how do you deal with maternal fetal health to prevent cardiovascular risk in the offspring. So we start everything in utero. The in utero environment programs our future, and that's the word in the title is the womb to tomb makes a big, I think that is more appropriate to say that. It is scary, but it is important to deal with it. The prevalence of maternal diabetes has reached its epidemic proportion that we need to look at the in utero environment, which is the key determinant of long-term health outcomes for these children. We all know that poor metabolic states like maternal diabetes, overweight, obesity, along with placental insufficiency is strongly associated with long-term health risk. And so I was very fortunate that I got trained. My mentor at Columbia University in New York was a guru of fetal cardiology, Dr. Charlie Kleinman, who introduced me to the concept of fetal cardiology, basically taught the techniques. And then when I returned back to Minnesota, I was fortunate to establish a fetal cardiac program in 2004. At the time, I started to establish a clinical program where I said, I am on call 24. Please send me any fetuses you think is abnormal or you just cannot see the cardiac anatomy. And I was able to build this program anywhere. We started with about 100 cases, and now we are close to 1,700 fetuses we are screening per year with our 3 fetal cardiologists in our program at this current time. And with the mentorship from Dr. Moeller, I was able to he said, think about your clinical volume is increasing. What do you want to do with this, with information? Start putting together and start writing up. And this, in 2008, I was able to establish a fetal cardiology database collecting all the information from the mothers, infants, as well as the fetuses. So I'm up to about 4,100 patients with the help of a lot of volunteering medical students who are put together the data. And I started seeing a trend over the past 10 years, and I've collected about 1,100 mothers with the diagnosis of maternal diabetes. So I started working on my database and wanted to study the fetal cardiac output as well as the fetal vascular characteristics. So I started a study number 1 and study number 2. So I'm going to present my data for both studies So study number 1 is mostly targeting the fetal cardiovascular system. Is it changing or is it the same? So these are the maternal characteristic for mothers with diabetes. N was 532. Yes, I collected 1,100, but I don't have all the data on all these patients. I was able to get about 532 patients in one, and here are pretty much they're similar how they're screened in our center. So these are all normal, structurally normal heart who are presented to our institution for just screening purpose. That the mothers are very big, they're not able to clearly. The mothers are obese, overweight. And I will discuss my data shortly, but the reason why these mothers are sent for screening is that they can't see the heart clearly. They cannot rule out congenital heart disease, or there was something polyhydramnios. There was some clinical indication for us to look at the fetal heart closely. And then I compared it to the fetuses who were not exposed to maternal diabetes but came for other clinical indications, like there was family history of some type of congenital heart disease, but they all had structurally normal hearts. So type 1 diabetics, 31%, type 2, 35%, gestational was about 32%, and I wasn't sure about 4 patients what they had. So it's important for documentation. So I think it's as a healthcare providers, we really have to pay attention to height, weight, and put together all the data in the chart so that it could be a useful research tool. The delivery, look at the deliveries for diabetic. 64% were delivered C-section versus 32%. By national standards, national data that has been published, it's about 32% of the population are only C-section deliveries. So clearly the numbers are higher. And this is another maternal data that shows hemoglobin A1C in our group is a very highly controlled population. So it's about 6.39, median about 5.9. The weights are much higher compared to the normals. Heights are similar, ages are similar. BMIs are about 32 to 33, which is of concern. This is a couple of slides are pretty busy data. So let me point out the salient features are the weight. This is a normal patients that the number was about 103 patients. I've collected the data. Diabetics were about 524 or 530. And look at the weights. The weights are much higher in diabetics. The BMIs are higher. The p-values are clearly significant. And the hemoglobin A1Cs we have obtained only on the diabetic moms. So normal mothers, the non-diabetics did not get their hemoglobin A1C. So about 6.39 is not bad for a mother who's pregnant. And look at the mode of delivery for diabetic versus non-diabetics. 34% were vaginal deliveries compared to C-section of 66 versus a normal of 65 to 35. This is an alarming number, which means it involves a prolonged hospital course, complications are higher, medical cost is higher. And as I said, the next one is also a very busy slide. So we looked at this data very carefully about on 523 diabetics compared to 103 normals. The salient feature is that the LV output, as I said, in fetal life, the normal part, the RV takes over 60% and LV is 40%. And RV has more output than LV. In diabetics, the LV output started to be higher. The ratio, RV-LV ratio is lower in the diabetics, and the combined cardiac output is higher in the diabetic pregnancies. And then we started looking at, Julia was more into, Julia Steinberger, she loves to, her work is mainly on left ventricular mass, left ventricular thickness. So she said, why don't you start looking up the LV posterior wall or all the masses, LV mass during systole, diastole. I'm looking at these are very tight controlled, structurally normal hearts. This is only during second trimester. This is part of the screening tool. I haven't even started looking at third trimester. Second trimester is alarming because these are very tight controlled pregnant mothers this is how we measure the LV wall thickness in utero. This is transthoracic echocardiogram just to show the comparison. And these mothers are not easily, you can get these images. It involves a lot of labor, a lot of hand labor if you talk to my technicians to actually obtain a data like this. LV posterior wall thickness was very significant even during the second trimester with the p-value of 0.033. And this is a box plot showing the RV output in diabetics are slightly lower compared to the normal. The LV output is higher. So the ratio is actually altered, saying that the left side cardiac output is slightly higher compared to the right side. So there's some type of adaptation is going on. And the combined cardiac output is also higher in the diabetics versus non-diabetics. In summary, this is a part of my first part of the study. The diabetic mothers had a significantly higher weight, BMI, than non-diabetic mothers. There was no significant difference in maternal age. Diabetic mothers are more likely to get C-section than non-diabetics. And the combined cardiac output, the left ventricular output, the aortic diameters were all significantly larger for diabetics. And the RV output was lower, and the ratio was also lower for the diabetic pregnancies. And the LV posterior wall was significantly larger in the diabetic group. So what does it represent? What are these changes, and why does it happen? This is representing some type of adaptive mechanism that's going on. It could be placental, it could be multifactorial, it could be fetal. The fetal is hyperinsulinemia may impact fetal vasculature. We know that diabetic itself is a chronic illness with some type of inflammation is going on based on some of the blood works that we have seen both in animal model as well as in the human model that can influence the developing organ. And the placental changes is placenta is responding to some type of hypoxic event or increased oxygen demand to the developing heart, at the same time to the developing organ. And that's probably what I'm hypothesizing is the LV outputs and the combined cardiac outputs are higher. So then if the left side output is higher, clearly there should be a lot of blood heading towards the fetal descending aorta. So my second study was to look at the vascular characteristic because that is the earliest cardiovascular risk markers. I am really fortunate to work with Don Denagle in the vascular team to look at if I give you guys an abdominal aortic loop, a cine loop, will you be able to automate this kind of vascular characteristic? And we started sitting down. It took us 2 years to actually even starting to look at these vascular characteristics on a couple of our patients. We all know that there is evidence that maternal diabetes may result in increased aortic intermediate thickness in newborn patients, in newborn infants. And measuring the IMT has been shown as an early marker for the risk of cardiovascular disease in children and young adults. There is very few even literature available for looking at fetal vasculature, but I started looking at fetal abdominal vasculature. So this is the first study actually in the literature to evaluate the vascular characteristics. And we all know that decreased arterial compliance is an early manifestation of structural functional changes in the vessel wall, which needs to be investigated further. So my objective in this study was to look at feasibility first. Can we even look at the IMT in the second trimester? Compliance, distensibility of the fetal abdominal aorta when you compare to the diabetic versus non-diabetic pregnancies. And what is that? What does compliance means? How easily a blood vessel expands is the elasticity when it's filled with volume of blood. Distensibility is the ability to stretch. So if you know that the compliance is lower, which tells you that there's arterial stiffness, which is common finding when you're in advanced age, both men and women. And increased arterial stiffness is associated with cardiovascular risk factors such as hypertension, hypertriglyceridemia, type 2 diabetes, and as well as part of the aging itself. The more arterial stiffness, it impairs the ability of the arterial system to handle the spontaneous elevation in the blood pressure during systole. And what happens if you have increased systolic blood pressure, the left ventricular afterload with the subsequent increase in myocardial mass as well as decrease in diastolic pressure, which will lead to diastolic coronary perfusion, could be compromised. And so decreased compliance is one of the earliest detectable manifestation of adverse structural functional changes within the vessel wall, and the current understanding for altering maternal metabolic health and reducing cardiovascular disease risk transmission to offsprings is limited and needs to be studied further. So I started working on study number 2 using the fetal abdominal aorta. This is not something fancy. This is on a routine screening. We can do it as long as the baby is able to, the fetus is able to give me those pictures. So I was able to get about 41 patients to be in this data. 25 are normal fetuses because it's very hard to scan an abdominal aorta normal fetus versus a diabetic mom who's very big with the BMI, and it's hard to actually go to have a good resolution of the abdominal aorta. 16 patients were part of the study. This is during second trimester, 24 to 25 weeks, using a conventional fetal echocardiography. And we took this to the fetal, to the vascular lab using an automatic technique, but I also was part of sitting down. We did as a, not only automatic technique, but I used some calipers along with Nick so that we started using, how to measure these abdominal aortic measurements. And we had, finally utilized the automatic technique to determine the abdominal wall characteristic. And these images were analyzed using a computerized automatic wall tracking software to look at the intima as well as the compliance and the distensibility. So here you start to appreciate, again, this is a fetal echocardiogram, and I'm going all the way to the distal aorta because that's where the aortic intima will start to be more thicker rather than the proximal part of the descending aorta. Again, this was obtained about 20 weeks of gestational age, which is a very good imaging plane. And this is how a report is generated after the analysis, looking at the intimal thickness, the far field we call it, and the near field, and then start to generate the compliance and the distensibility. And I'm presenting the data for 25 normal, 16 diabetic fetuses. Look at the compliance and the cross-sectional compliance for the diabetics. Actually, to our surprise, the compliance was much better. So first we proved that it is feasible to measure IMT, compliance distensibility, during second trimester for both diabetic and normal pregnancies. To our surprise, the diabetics had a greater compliance in the vessel. The reason is not known, but we speculate that there is a period of adaptation, which is a good thing. Arterial remodeling is underway during second trimester before we set the stage for maladaptation or getting into arterial stiffness either during third trimester, or clearly in our literature we have shown that newborns do tend to have significant arterial stiffness if they are exposed to a different kind of in-utero environment. So this potential prenatal cardiovascular remodeling may set the stage for vascular changes and cardiovascular risk that needs to be further investigated. This process may indicate that there is an opportunity for intervening these fetuses around the phase where it's second trimester. Third trimester might be a little bit late. And so future is that prevention. So let's talk about prevention. How do you prevent this? We have looked at gross malformations and we said, okay, let's reduce the maternal mortality, morbidity. Let's talk about fetal. Let's fix the heart. Let's fix the other or other congenital anomalies. But now let's talk about more in depth of vascular and tissue characteristic, and we can change it if it's possible. So intervention should be targeted to those fetuses who are high risk during second trimester. How can we do that? Encourage mothers to improve their diet, increase physical activities, healthy weight gain during pregnancy, meeting with the trained dietary experts, or counselors, and individually tailored for their diet or exercise planning should be investigated. But how do you do that? How do you know it's a high-risk fetus? We come into play using the non-invasive imaging. And non-invasive imaging these are some of the non-invasive imaging that is recently available, or for the past 20 years it's available, using 2D technology, and then the color flow imaging, looking at the flow patterns in and out of the heart. We were able to, so I was able to do my work with using these type of technology, but we need to go further. The further is advanced imaging, advanced 4D data set and 3D data set, tissue Doppler imaging. We can do it. It's a matter of getting to know the technology, working with the technology, and automating everything. Again, this was research, and I spent a lot of time working on cardiac outputs, and we just cannot immediately generate this kind of report. So we need to try to generate these reports as we are starting to see the patient in the clinical scenario, and try to do these volumes, look at the cardiac outputs, and look at the tissue characteristics and identify the high-risk pregnancies and start working towards preventive strategy during the second trimester. So my summary is that maternal diabetes, overweight, obesity is on the rise. We have started seeing changes in the fetal cardiovascular system, even with the tight control of hemoglobin A1C in second trimester. Preventive measures need to begin in utero. That's, I think, starting second trimester or even the first trimester, if it's possible. Maternal health monitoring very, very carefully using a multidisciplinary team. We are trying to set that up with endocrinologists, nutritionists, and catering to different ethnicity, I think, is very important because the way they understand why do you need, once a baby's out, things should be fine, right? And so I think evidence-based knowledge needs to be talked with these families, and just monitoring the weight gain very carefully. And fetal health is very, very important in utero, identifying the high risk and follow through the third trimester and doing something about it postnatally also, so that we can prevent early cardiovascular risk. And I really have to acknowledge the people who have mentored me all these years and molded me. The first ones are clearly from India, Dr. Murli, who is a cardiac surgeon, and then Dr. David Hunter, who actually walked me when I started at 24 years ago at University of Minnesota. David and Mitch Einzig, like a kindergartner, talking to me about how to go to the cath lab, how to look at the images in a very different way. And then Dr. Moeller, who absolutely told me to work on the fetal database. And Charlie Kleinman, my mentor at Columbia, who passed away, who's a fetal cardiology guru, Dr. Quagerberg, who actually taught me operating room techniques. Dr. Q, he's one of the PhDs in arterial switch procedures. I was very fortunate to work with him. Clearly, Bill Hellenbrand, the interventional cardiologist, Dr. Bass, Dr. Steinberger, my patients, Dr. Gersney at Columbia University, and my son, who keeps me in check all the time. Mom, just be grounded, just be a mom to me first, and then let's talk about other things in life. And I really thank all the people who molded me. And I would like to see a healthy mom and a baby in future. Thank you for your time. I can take any questions. Go for it. Tony, of all the people, I have to acknowledge her. She was the one who actually said, Shanthi, be on the spot. And she looked at all my slides before even I presented it today. So thank you, Tony.
Well, thank you. That was a lovely presentation. Over the last few years, we've gotten more and more tools for taking care of diabetes. The women in this series with an A1C of 6, there's no way, at least with tools we have right now, that we could do better than that for diabetes control. We've seen gross malformations decrease, and I think that we have all had sense of what appears to be false security that we're getting on top of the problems. So it is disturbing, but important to see that in these well-controlled mothers whose babies don't have major malformations, you're already seeing significant changes in the second trimester.
Yeah.
So now you have a lot of work ahead of you to figure out what that leads to, but it's good work and it's all totally new.
Thank you. Thank you very much.
So I'm curious, in your first study, you had roughly equal numbers of type 1 and type 2 diabetics. Did you compare and contrast those two groups?
Yes.
Were there differences, and what did you find?
I think it was exactly similar. So I did look up type 1, type 2, gestational, all three we ran the data set on. It's exactly the same. The cardiac output redistribution is pretty much the same. Yeah, and I will be publishing this paper in 3 different papers, because one is the other one is probably type 1, type 2, and gestational diabetic groups. Yep. Yes, Angela.
In the second study, I don't understand why you think the increased compliance was a good thing and that it was compensatory. Because to me, it implies that, the extracellular matrix is not well formed, and then that sets it up for the compensatory increased stiffness later.
It could be. I don't know the answer. That's a very good point. When we were discussing with the Don's group, he felt that he is starting to see those changes in children's and newborns when the compliance initially was better, and then I was able to show that in fetal life also. He felt that this is an adaptive mechanism to start with. I don't know if it's a good or a bad thing before we get into a lower compliance, but we'll take a look at it further. Julia had funded me for another about 100 patients, so hopefully I can get some more data available for you guys. Yeah. Hi, Matt. Yes.
Hi, Shanthi. I have
Sorry,
two questions.
Yes.
The first question is, are you planning a long-term follow-up of some of these fetuses as they are children and adolescents to see about their cardiovascular health? That's the first question. And then the second question is, what are some of the factors that we can think about that are important in the causation of the congenital heart defects, because the heart is already formed by second trimester. And so the congenital heart defects would occur earlier, as you know. So what are some of the factors about the initial part of a diabetic pregnancy that might predispose to those?
Good points. The first question is, what about long-term follow-up? I need basically, so I have to go after Joe or Angela. So Dr. Neglia, you heard it. So I will be tapping into your office now. And yes, I would love to follow these kids. They really are at a very high risk. That's what I think. I think it's a whole family, because I see them. The moms are bigger. They come with their siblings. They're also very big. I don't want to be biased, but when I see those families walk into the fetal clinic, they're all big. They're overweight. The whole family needs to change. The concept of healthy living and wellness program has to be initiated, and that's what my goal will be, to set up a long-term follow-up for these fetuses. And they're all within Minneapolis. I did a quick survey, and the family said, we would love to see you again. If you have funding, we'll be happy to bring our kids for further evaluation. The second question is that, what can you do during during the 8 weeks of organogenesis period? I have to work with the endocrinologist, MFM obstetricians, to figure out, is it multifactorial, or what can be done to avoid major congenital anomaly, just not congenital heart defects itself? How do you have tight control of you don't even know you have diabetes. Majority of the women during gestational time, they don't even know they are. So do we have to do pre-screening who are all in the childbearing age group? I don't know. I would probably ask Tony about it, whether these adolescent to people who are in the childbearing age group needs to have a very tight evaluation needs to be done as a pre-screening. Matt, sorry, go for it.
That was mostly my question.
Thank you, guys.
You have been disconnected from the meeting.